Thank you very much for having me here. It's an absolute pleasure. I've literally arrived in Victoria yesterday, so I haven't seen your great town, but I've spent the weekend in Vancouver, and that I had hoped to spend more time in the presentation, but Vancouver was just, I couldn't not go out and see it all. So yeah, apologies. It kind of comes to an abrupt end, as you'll see, but blame Vancouver for being awesome. I also feel I feel a complete fool coming here and actually reflecting back on a lot of work that's come from this department and from Tim, who I really admired your work. So I'm kind of talking back to you about stuff you already know. I wasn't sure who the audience is going to be. So are you all working in addiction? Is that kind of who you all are? No? But
just general interest public.
Okay, all right. So some stuff will be very, very familiar to some people, but perhaps some not. So I've kind of pitched it hopefully at the right level. So yeah, I'm going to talk maybe for 40 minutes. I said to him, I haven't actually timed this, so I have no idea. We could be here all afternoon, or we could be done in 10 minutes, and let's see. So this is kind of my putting together where I sit on the fence about this. I'm often asked, is there a health benefit? I'm sure guys working in the area, you are as well, and I don't have a neat and quick answer, but so this is some of my thoughts on the issue. So, just a bit of background. We all know the harm that alcohol causes. Just a couple of statistics there. So, 3.3 million deaths each year are estimated to have been caused by alcohol consumption, and that's about 6% of all deaths, or 1 in every 20 deaths in the world, which is, really quite staggering for a behaviour that we don't actually have to do. It's a choice thing. And this is picked up massively in the media. We all know that almost daily in the papers, particularly, I don't know if it's the same here, but in the UK, that we have the paper, the Daily Mail, absolutely goes to town on this. Headline pages, front page stories about how bad alcohol is. And the long-term effects of alcohol, I guess, again, talking to some of you who work in this area, almost every system in the body is affected by what we put into our mouths in terms of alcohol. And in a paper fairly recently, Robin Room, the godfather of alcohol epidemiology, was saying that there are 60 medical conditions that alcohol has been identified as being a causal factor. And this includes everything from mouth, throat, stomach, liver, breast cancers, depression, pancreatitis, liver disease. So we know all this. Alcohol's bad, right? Okay. But what about the flip side? What about the idea that it could actually be good for us? And again, the media love these kind of stories. Drinking wine can fight diabetes, a glass or two may prevent dementia. This one, bit random, alcohol's good for your health. The leading science writer claims tipple can prevent cancer, bit odd, and may help improve your sex life. So worth checking out that one. And how do we know all this? Let's step back a moment and think, where do we actually get this evidence from? And broadly speaking, there's two ways of doing this. We either observe people, or we do experiments where we give them drink. And these studies go way, way, way back. So let's start with the observational studies, where scientists, looking like this, very serious, with clipboard, observe people drinking, how much they drink, where they drink, and the health consequences of doing so. Now this is a classic U-shaped curve. You've all heard of this U-shaped curve, right? So the idea being, if you compare non-drinkers, there's a sort of U-shape where it's better, it's more, this is total mortality, it's actually a lower risk if you're drinking sort of lowish, moderate amounts, and then it goes back up if you're drinking high levels, it's harmful. So this is a little bit, and altogether this is total consumption, total mortality, and this was a big, big study of, I think, about 34 prospective studies pooled together in a meta-analysis, and this figure is often shown. So that's for total mortality. This one is a very recent paper, 2017, looking strikingly similar, and here they use data from different separate waves of the National Health interview surveys linked to death records, and found a similar shape, this U-shaped curve. Now let's move to the heart disease, because a lot of that mortality, total mortality, is arguably driven by it being good for your heart. So this is another curve that's often shown. This was by Roecker, I think you pronounce. Roecki. Rorecki, okay, we'll go with that, Rorecki and Ream, back in 2012. And here again, this was pooling data in a meta-analysis and showing this sort of U-shaped curve here. So you've probably all seen those. That's quite familiar to us. Another way of doing it, so not pooling together in this, the prospective cohort studies in the same way as the previous ones were. This was a piece of work which I was very, very loosely involved in, I have to say, very loosely. But Tim did say I published in the BMJ, so there you go, that was in the BMJ. This one, we again, loosely, had 2 million people, data on 2 million people from their clinical records of what they were drinking, and this was linked to electronically to outcomes. So it was population-based cohort study, linked to electronic health records, so it's from their primary care, linking to hospital admissions and mortality. And the point was here, we had such a big sample that we were able to disentangle a bit this sort of broad package of cardiovascular disease. We chopped it up into 12 different kinds, because we had the power to do that, the sample size. We found that moderate drinkers had a reduced risk for 7 out of 12. So it wasn't ubiquitous. There were sort of differences in which harms they were protected from. And we argued then that this actually is quite important to know in terms of, well, basically we needed more research and we needed a more nuanced approach to the role of alcohol in the prevention of cardiovascular disease. So it's just another piece of evidence looking in a slightly different way, but we did still find a protective effect in some presentations of cardiovascular disease. Okay, so why might we be sceptical of this? These are huge, huge studies. They're not single studies. So we need to take a think about who are the comparison groups, who are the drinkers, who are the non-drinkers. And here I'm indebted to people long time before me who've been doing work in this area. So we need to think, who are the non-drinkers? Are they lifetime abstainers? Are they former drinkers? And this is where we think about this sick quitter syndrome. That's the one, yes. So people who were former drinkers, they quit because they become unhealthy. So it inflates the risk of non-drinkers because they're actually quite poorly themselves. We need to think about, who are these moderate drinkers? Are they representative of everybody? And selection biases, how they might come into it. And then I'll say a little bit about changes in drinking over the life course, which is something that I've been working on for the last couple of years. So very briefly, because I know this will be familiar to most of you. So the non-drinkers, we need to think, who are they? Are they lifelong non-drinkers? Should we have the reference group as occasional drinkers? And bearing in mind this sick quitter people. So here is, this slide is basically just showing that comparing former drinkers and lifetime abstainers. This again, I hope you're familiar with this kind of, these are the individual studies, this is the meta-analysis result, pooling it all together. And when they were combined, it showed that the former drinkers had a higher risk of heart disease than lifelong abstainers. So it's just saying again that you shouldn't really muddy the water of having non-drinkers to include this mixed group of people. But then again, you see, if you just take people who've never drunk alcohol in our society, in the Western world, that's actually the norm probably, is to drink a bit. So people who don't drink may be different, or choose not to drink, may be different from the rest of the population. And this was a piece of work that came from some colleagues in my department who showed that even right from an early age, people who were non-drinkers were sort of selected into that because they were actually quite poorly. They didn't start drinking because they were already poorly. So again, you've not really got a fair comparison when you're doing these studies.
They were already what?
They were already poorly, so they had poorly, so they were already ill.
Okay.
Yeah, so they started off ill.
They were also poor.
They were probably poor. Yes, I think you're right. Yeah, they were poorer and poorly. It's hard to say. Okay, and then here, this is work, Tim, right in front of me, in a very great paper back in 2005, where, correct me if I'm wrong, but you showed that you looked at 30 different cardiovascular disease associations and basically risk factors, and basically showed that moderate drinkers are themselves a healthy bunch. Yeah, they were younger, more likely to be married. higher education, richer. So really neat, just showing actually these moderate drinkers have a lot going for them anyway, regardless of moderate drinking. And so this brings us to the issue of residual confounding that we're particularly concerned about. So if these people are healthier generally, we would expect to see them having benefit from all sorts of things, and we do. Look, this nice slide, one of my daughters did this with all these things popping up. There we go. All these different conditions. Moderate drinkers were coming out as having, it looked like moderate drinking was protective. I mean, you start to wonder, hearing loss, low birth weight, how's that actually working? Yeah, so we should be getting concerned. Oh, there's another one. Oh, there's more. Oh my goodness, there we go. Okay.
We're selling wine outside.
Okay, now this really is speaking to the people who've done the work. So if this U-shaped curve, if you chip away at different ways, and you've been chipping away, right, chipping away at this U-shaped curve, showing that the more rigorous the analysis, that U-shaped curve starts to disappear. Maybe not disappear completely, but yeah, it's going. So here, this paper, very recent paper, correct me if I'm wrong, but this figure was showing basically you do see a protective effect if all those studies are pulled together. Yeah, so this is updating the meta-analyses that's been done before, but this was the interesting figure for us in this message here. This was if you just look at younger people, 55 and younger. If you start off with quite a crude way of looking at it, there is a protective effect, but the more rigorous the analysis, the more different covariates that it will put in, and you come up to a fully adjusted level, really that doesn't seem to say to me that there's any sign, there's no statistically significant difference there between low volume alcohol and lifetime abstainers. So the message that alcohol is good for the heart, well, it certainly doesn't look like it for younger people in this analysis.
Andy, can I just add
Yes.
that these were people followed up to old age as well, so their measures were taken before 55.
Right.
But they're followed up to advanced age when they might get heart disease, so it's not that they're too young to get heart disease.
Sure, right, okay, yeah, good point. Yeah. This figure, Tim may recognise. This I really liked. I think this is a really neat way of showing, we're talking here about selection bias now, not the sort of confounding before, but here at almost every stage there's selection bias going on. So we start off with that people are born, they either choose to drink or not drink, and I've already said a little bit that maybe people who don't drink, they're already sicker, there's already something a bit different about them. And we go off on this path, some of the drinkers will die. So maybe here, actually drinking is bad, but because this is when a study might start, they don't even get in the study because they've already died. So you've got selection bias, bang, 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 pretty much everywhere. Here we go, and there's one more I think coming up here. Yeah. So when you're trying to compare this neat group who you would think is like moderate drinkers versus non-drinkers, you've actually got a really selected bunch of people in here. And on balance, I think Tim, you were saying that the selection of effects here are basically making out the moderate drinkers to be a better, healthier bunch of people in comparison to non-drinkers. So it's pretty loaded that you're going to find that drinking is beneficial. So I like that figure. Okay, I'll say a little bit about some work I've been doing about the life course perspective. So basically the issue that I had was that most of the studies that we have, this plethora of cohort studies, take a measurement of alcohol consumption at baseline decades ago, and then they assume that measure is an accurate measure of their whole lifetime's consumption, and they follow them up until they die. So I would argue that this ignores that there's changes in consumption over the life course, and that there might be accumulation of effects, or there might be critical age periods. Does it matter if you binge drink in your teens and then you don't drink, or as you get older you drink? Does that kind of thing matter in terms of these risks of chronic disease? And I think in the data in the studies so far, that's not really been pulled out. So this is the kind of thing we're looking at. We've got some different trajectories here: early adulthood, midlife, older age, and this might be someone's drinking goes up, this one's down, these top ones they stay steady. Okay, something like that. So if you were to do a study and take a measurement there in midlife, bang, it has completely ignored that they used to be a heavy drinker. Okay, that's a very simplified way of looking at it. So the first thing we did in this project was try and map out what do these trajectories look like. So we got hold of a whole bunch of data, and this now is actually, we've got some other studies from other countries. Most of these were, well, they're all British. And I say we got hold of a bunch of studies. Actually, that was quite a hard process, getting permission to get some of these studies, as I'm sure you can imagine, people who share data. Some of them are in-house from the department I work in, some are freely available, others I had to beg, borrow, whatever, to try and get their data. Really quite a lengthy process. But what the inclusion criteria for me was that I wanted these studies to have had at least 3 measures of alcohol consumption on the same people as they're getting older, so that we could try and stitch together what happens over the life course. So the first really big task was to try and harmonise the data. As you can imagine, each of these studies is asked in a different way. They've asked about alcohol in a different way. But we managed to kind of tease out a mean weekly consumption, and we also got a measure of frequency from each of the studies. And then we thought, well, we really need to adjust for covariates because they're all quite different studies. So again, we tried to harmonise just some of the basics that we thought were essential: smoking, social class, physical activity, diet, ethnicity. And in some studies we had more, but that was kind of what we could get across the board. And our outcomes of interest were primarily death, coronary heart disease, and a whole heap of biomarkers if the studies had them, which some were very rich in and some less so. So this figure looks a bit of a mess. I've got the next one sort of pulls it together. So this is just to show you what we did. So each study is a different line. So some studies only contributed like a first portion of life. Very few covered everything. The longest one we have is the 1946 birth cohort. So those people really have been followed up for a long time, but that's quite a small one. That's NSHD, I think. So that was men, that's women. That's what it looked like initially, but then we kind of pooled it together and smoothed it in some nice statistical ways that I'm not going to talk about. And this in a nutshell is kind of what we found pooling all this data together. As you'd expect, men drink more than women, no surprises there. This is in the UK units, I'm afraid, which is very poor of me, but 1 unit of alcohol is about 8 grams, so 20 is about 160 grams of alcohol. Is that what you guys talk about in alcohol? Do you talk about grams of intake?
People know standard drinks. It's about a unit's 2/3 of one of our standard drinks.
Yeah, it's slightly smaller, isn't it? Yeah. Okay. All right. So hopefully that helps. Big peak for men, but then tails down as they get older. Women, a bit shallower, plateaued over.
This is per week?
Yeah, it's a measure of average consumption per week. And we were able to go right up to sort of pretty old age because some of our cohorts were really old. So from that piece of work, we were able to show, well, we knew this, right? We knew that alcohol isn't a stable thing. So there's no good just taking one measure of alcohol, bang, and assuming that it's representative of the whole life course. That's what that piece of work was about. This is a slightly different way of looking at it, and I think this is a paper we talked about, like the stability of baseline consumption. I think we talked about it at one meeting that we might have a go. So we did this. It's basically showing these are the different classifications of people at baseline, what they were. So here, for example, this person is drinking 50 to 100 grams per week on average, but they really don't stay doing that over time. So those baseline categories are really actually quite inaccurate and erroneous way of looking at it. Okay. So all well and good, we know drinking changes over life, but does it actually matter in terms of the estimates of when you're estimating these risks? So one of the measures, I said we looked at biomarkers where we had it. So one of the things we looked at was your thickening in your carotid artery. There were 2 studies that had that measure. And basically, it's the thickening of the vessel wall, and as it gets thicker, it leads to heart attacks and stroke. And it's called the carotid intima media thickness, CIMT. So 2 of our studies had that measure, the Whitehall 2 cohort and the 1946 British birth cohort. So the Whitehall 2 cohort is a study of 10,000 civil servants who were working in the UK government back in the 1980s. There were about 10,000 of them that we've been following up now for 30 years. That's the study I work mainly on, so I'm very familiar with that one. And then the British birth cohort, the 1946, that was about 3,500 people born in 1 week in Britain who have been followed up until now. They're in, gosh, I can't do the math, 70 something. Anyway, followed up for a very long time. So we had a combined sample of the people who actually had the measure was about 5,400 men and women, and we had 20 years of drinking trajectories, and then this measure of CIMT when they were about 60. So for Whitehall 2, we got a measure of alcohol consumption across phases 1, 3, 5 and 7, and the outcome was measured again at phase 7. So we've got this before and then CIMT then. And that just shows, well, here we have selection effects coming into it. We started with 10,308. By the time we actually got this measure, we're down to 4,000. The reasons for that being some of them have died, some have left the study. Some of them didn't want to have this probe done. Yeah, so we need to have that in mind. Who are the people left in this study? For the birth cohort, we had measures when they were 36, 43, 53 and 60. And again, the outcome was measured when they were about 60. So 5,000 odd start, but by the time we got down to that age, it's a much smaller amount left. So essentially what we're trying to do is, this is not real data, obviously, it's just showing if we were trying to compare people who never drank, or the consistently heavy drinkers, or as most people do, this is the largest group, they're a sort of unstable group. Yeah? Most people, 60% of people, have a sort of wiggly line. Stable moderates is quite high. These classifications of moderates, I think they're following the UK guidelines. I can't remember. It's something like about 14 units, so multiply that, maybe 10 drinks a week, is that?
Yeah.
And so we're going to try and compare these different trajectories. Does it make a difference which trajectory you're in? And comparing whether you took a cross-sectional idea of doing this or whether you look longitudinal. So, okay, bear with me with this slide. It's going to build up. So starting off here, this is former drinkers. If they're on the right-hand side of the graph, they have a worse thickening. They have a thicker CIMT. So here, pooled, Whitehall and the other study, when pooled together, so former drinkers, as we thought, are worse off. The mostly heavy, bit mixed. Mostly moderate, so these are people with wiggly lines but staying within mostly heavy or mostly moderate, building up to someone who's a stable heavy drinkers there. Actually, this has really got quite a lot of uncertainty around it, partly due to the sample size. I would have thought there we only had 1,000 odd of those people, and probably most of them weren't stable heavy drinkers. And the stable non-drinkers, not looking like there's that compelling evidence. So that's if you're taking account the trajectories. If you were to just do it as a cross-sectional analysis, so the only thing you can look at, this is compared to, I should have said, sorry, these are moderate drinkers as the reference group, moderate drinkers. So here the heavy drinkers, well, they're on the on this side, but I guess the error was very big there. And from all of this, I guess in a nutshell, what we were trying to tease out, believe me, we really tried to tease out what we could here. If you'd done it cross-sectionally, you would say that heavy drinkers, it didn't matter. You could drink as much as you like. If you were looking in long term, you'd say that yes, actually being a stable heavy drinker is really bad. Don't read too much into. Yeah, sorry, go Tim.
No, for the left hand, the reference group is that stable moderate.
That would be stable moderate. Yeah. So that's, sorry, I should have said that's a one-off moderate measure because you're just doing it one. This would be the stable moderates who were 30% of the people. It's quite a big group.
Can I ask, how former do you have to be? Like, how former is former? What made the difference? Do you ever go back to looking more like a non-drinker? Where does the transition happen?
Yeah, good question. We haven't really tested that. We can do. The people in Whitehall 2 were aged 35 to 55 to start with, so in some ways we have a bit of information about them before. This study, we followed them from birth, so we should know exactly. For this piece of work, I think if you'd ever drunk, if you said you'd drunk at all before, you were classified as former, and then from when we started following you, if you were saying you weren't drinking, but you had told us previously, I think it's something like that. I need to get the paper to remind myself how we did it. Okay, so that sort of model, we then repeated in other ways. So the carotid IMT was just one thing. We've looked at pulse wave velocity, we've looked at adiponectin, we've done it now in fatty liver disease, we're just about to publish some work where we actually use coronary heart disease, which is essentially what we wanted to do. That's our ultimate thing, so that one's just coming out. And I think it's fair to say we've really probably done as much as we're going to do on this. We've,
Did you look at total mortality?
I don't think we've got enough numbers.
No.
I think even amongst all those studies pulled together,
Yeah.
I could be wrong. The paper that's just about to come out might include some estimates of mortality, but it's going to have quite a lot of error around it. So it'll be measures of coronary heart disease like self-reported angina or doctor-diagnosed, that kind of thing. So wait and see. That one's about to be submitted. Okay, so we really milked that, and our conclusion was, yes, it does matter. Drinking isn't a stable behaviour. Your past drinking does have an effect, and where possible, you should always try and take account of this life course approach, and hopefully that might improve the evidence base a little bit. Okay, a few words I'm going to say just about what are the mechanisms. So I showed you that slide where everything floated up, all those different diseases where you think, hang on, how can moderate drinking be protective for hearing loss, blah, blah, blah. But there's absolutely tons of information on what the biological markers behind this might be. This paper gets cited a lot, Britton in the BMJ. Basically, they looked at a lot of studies that were intervention studies where people have been given alcohol in particular doses, and they reviewed all that literature, pulled it together, and they argued that higher levels of high-density lipoprotein cholesterol and adiponectin and lower levels of fibrinogen provide indirect pathophysiological support for a protective effect. So they were pretty confident there is something behind all this in terms of biology. The next, I think it's this next one, I love this, I don't know if you've come across this paper by Matthews et al. It was in Nutrition Journal in 2015, and they wanted to come up with a high-level conceptual model linking alcohol and pathogenesis of CHD. They wanted the ultimate model that shows it all, and I was very excited to see what they'd come up with. And this is it. That's what it literally was published, and not as a joke. And they actually say, they quote, "It is now clear at a glance that moderate alcohol consumption increases HDL cholesterol, insulin sensitivity, and adiponectin, while decreasing inflammation, all of which have a positive effect on CHD." I actually thought that was a joke. I mean, even if you zoom in, you know, there's that. Well, I don't find that particularly helpful, but there we go. Have you come across that one? No. Well, yeah, one to look out for.
It's all clear now.
It's all clear now, right? Yeah. Okay. So I'm not going to go through this in detail, but even though this biological evidence is pretty compelling, the risk factors that people have found that alcohol is associated with, there's now evidence to say those risk factors are maybe actually not linked to CHD, so the pathway isn't quite there. So some of the things, there have been studies showing that some of these markers, adiponectin, whatever, that they don't actually causally link to heart disease. So how can that kind of chips away at the evidence that alcohol is affecting this pathway? I'm not going to say a huge amount more on that, as there's so much literature. So, okay, if we can't trust the observational evidence, what can we do? So I'm going to say a little bit, not too much, on something about experimental studies and the idea that maybe we could do a randomized controlled trial, a few words on Mendelian randomisation. So there are experimental studies. Let's not overlook them. There was a review of these studies back in 2011, I think, where approximately 60 experimental studies where people were given a dose of alcohol and some sort of biomarker was measured. And there's a review of that in the BMJ. There have been some small RCTs, okay, so it's not impossible. And then there's going to be this mega big trial starting. I'll say a few words about that. So is it possible to do an RCT? Well, there really have been very, very few. And when I say do an RCT, I mean one that's actually based in a population for a significant amount of time. So say ones that have been going for 2 years, I think there's maybe one, maybe two. There's this one from Israel where non-drinkers who had diabetes were randomly assigned to drink mineral water, white wine or red wine, and they were given that free of charge for 2 years. And then their health was looked at afterwards. And compliance, I think, pretty fair to say, was quite high. 80% in all 3 arms, apparently complied with what they were given. And attrition was was highest in the red wine group, and this probably so more people assigned to have red wine actually didn't carry on doing it, and that's probably because these people were non-drinkers. So they were non-drinkers to start with, and they've been told, okay, drink red wine. So I can't actually remember the findings from this. I think they looked at various markers and perhaps. I don't remember what the outcome of this was, but it's essentially showing that an RCT is possible. And here we have this on the horizon. Has anyone heard of this one coming up? Yeah.
So I didn't know the acronym.
Yeah, Mach 15.
It's supposed to be supersonic or something.
Yeah, Mach 15.
$100 million.
It's coming, yeah. So the start date for this is apparently any day now. It's in a few weeks' time, unless it's been pulled, as far as I know. It's been run by a group led by Professor Kenneth Mukmel from Beth Israel Deaconess Medical Centre. And it's going to be a multi-centre, worldwide, mega RCT, where people are given 15 grams, hence the Mach 15, versus not drinking. And they want to recruit 7,800 people. Bear in mind, the other RCT I told you about, the longest I could find was 200 and something. The people in the study are going to be aged over 50 and are going to have advanced cardiovascular risk. So we are not talking general population. That's who they want to study. It's going to last 6 years, apparently. So basically, they'll be recruited, they'll have a washout period, and then they're going to be followed up. They'll have some baseline measures and subsequently across the life. And this is going to cost a lot of money. The outcomes they're interested in are heart attack, stroke and death. There are a very long list of exclusions. So again, thinking about, can this RCT be extrapolated to the general population? Well, you've got to have advanced cardiovascular disease. You can have never had any drink problem. I'm not quite sure how that's defined, but there's a long list of people who won't be in it. And it's costing a fortune, $100 million. And it's supposedly coming through the National Institutes of Health, right? But it's backed by the 5 world's largest alcohol beverage companies. So before it's even started, apparently there's no strings, but there's an article in the New York Times that flagged up that many of the researchers who are leading this project have had close ties to the industry. So an RCT is on the horizon, but. It's going to be a very selected group of people. Whether they actually pull it off, who knows, and who is funding it. Is it loaded to find an answer? And you can imagine if it comes out that alcohol is protective, it's just going to go mega. The news is going to go mega, and it's going to have to be very carefully interpreted. Okay, a few words on Mendelian randomisation. So an RCT is really quite problematic. Have people heard of Mendelian randomisation? Yeah, okay. I'm just going to run through it really briefly. It's not my area, but it was kind of hyped as a really. It is clever. It is very, very clever. It basically uses the concept that a genetic variant serves as a kind of proxy for alcohol consumption. And if you can't randomly assign people to drink or not drink, if we had some sort of gene that did it for us, and if that happened at conception, which is randomly done, that could be amazing. So, arguably, it would get around confounding, it would get around reverse causation because you're given this from birth. And they came up with something that could do it. There was a variant of this allele, and it was a big study. This was amongst 260,000 people. This paper, Holmes, is cited all the time. If you're talking about Mendelian randomisation in alcohol, this is cited. It was in the BMJ 2014. So the carriers of this variant were shown they were less likely to drink, and they were more likely to abstain, and they were less likely to binge. So the genetic variant did what we hoped it would do. And it wasn't related, they said, to some of the other big confounding factors. So it looks like it's working. It wasn't related to physical exercise. It wasn't related to smoking. It seemed to be, okay, this is really neat. Something's happening without us having to do it. And they found that people who did have this variant did have a reduced risk of CHD, ischemic heart stroke, and several of the risk factors for CVD. And they showed that even amongst moderate drinkers, those who had this variant, it was better. It was, they were, if you had this gene that predisposes you to drink less, you had a better CHD health. So it's really kind of saying, well, okay, it's better not to drink, right? This was evidence saying this protective effect of drinking isn't real, and this was quite a neat way of trying to demonstrate it. And that gets cited a lot, right, as being compelling evidence. And I think it fits into the picture, but it wasn't perfect. And even the same authors, a year later, in International Journal of Epidemiology, and this wasn't picked up so much by other people, the same group of people did a slightly more sophisticated way of looking at of doing this analysis, and they used allowed there to be a non-linear relationship, because we think there is a non-linear relationship between alcohol and CHD. And they actually then themselves showed that there was evidence for a non-linear causal effect of alcohol on several traits. So they found that the best amount to drink was somewhere between 1 and 3.5 units. So the same people, I think it must have been on the same data set, actually came up with a slightly different interpretation. But this paper never gets cited as much. Everyone just shows the Holmes one that looked like it said alcohol isn't protective. So I think that's all I'll say on Mendelian randomisation. I think it's got a place. It's but we need to be very cautious about how we interpret it. So coming to a close. So we've got the science. I was quite pleased with finding these Lego figures. The science feeds to that's a journalist. Yeah, we have to be really careful about what the journalist. Wait for it. Look at that. Who's that? Ooh. Well, that one's pretty easy. Yeah. That one? Yeah, I actually found a Lego figure of your president. I know. So basically the science is picked up by the journalists, the media, by the politicians, and that in turn affects what we drink. And I really think that's kind of where I'm going to end it. I wanted... This is science, papers, saying all sorts of different things. The media pick it up and they interpret it in their own particular spin. So, just in a nutshell, and this is what people take home. 4 pints of lager a week harms fertility. Occasional drink may improve fitness levels. Okay, how does that work? A glass of wine a day is bad for you. Moderate drinking is bad, blah, blah, blah. I like this one. Mine's a pint, full of vitamins, high in fibre, low on sugar, and good for your hair. Benefits of beer.
Oh no, don't say that.
And this is what we get, right? Not many people are actually reading the science papers. We're taking home these messages. And here's this final little bit showing that people do actually take notice. So there was a study fairly recently. This was a paper looking at the perceptions on information sources and behaviour regarding alcohol and heart health. And they questioned 5,500 people. 30% of the people thought, yeah, alcohol's good for the heart. Yeah, definitely, okay. And of those people, 80% said they've got their information from the lay press. And not only did they think that, those who thought that alcohol was good for the heart, they were actually drinking more. So it was followed right through into action. So what's in the press does matter. And what I would have done if Vancouver hadn't have been so awesome was finish this off in a nice polished way, but here are just some final bullet points. Observational evidence needs to be interpreted cautiously. Combine it with the experimental evidence, but that's limited in what it can do because we're not rats. We can't, we can't. Long-term RCTs seem unlikely they're ever going to give us the answer, especially if they're funded by alcohol industry. And so I don't have a perfect answer at all for this, but I think we as the scientists doing all this need to have a better way of communicating what we find to the media and policy. Now that's probably a wish list because we can't control the media, but I've certainly been on the end of the phone to journalists in The Sun. I've said one thing and he'd already written his paper, he'd already written his headline without listening to a word I said. Now maybe that's my responsibility to hammer it home. Actually, I'm trying to say this, not what you're about to write. Maybe I shouldn't be doing that. Maybe there needs to be a person in between who does it for us. But I think there's definitely a role where we need to talk to get the messages out to the population so they know what to do. So I haven't answered the question, is alcohol good for your heart? I'm going to sit right on the fence and enjoy the view. So there we go. That's where I'll end.